I think we're ready to start. So this morning we're going to talk about the what has changed for 2015 as compared to our previous 2014 definitions. So I'm going to provide you a little bit of information about the purposes of the changes, the new definitions and their modifications, and we'll talk about some major changes that are specific to infection definitions, which for those of you that do use the manuals and do the surveillance, this is what we finally call as Chapter 17. And then I'm going to give you a little bit of information about the new data, the denominator sampling option that's available to your facilities. So really the purposes of our rather large changes to our definitions and our protocols in 2015 were those that are identified here. We really were trying, first and foremost, the Division of Healthcare and Quality Promotion. Is there an echo? Our major goal is to improve patient care in healthcare facilities. And so making sure that our definitions are consistently collected by facilities and that they are not, as part of that, there's not a lot of subjectivity in applying the definitions so that we can make sure that we're getting equal or fair data to compare between facilities and across the years as far as trends go. And we also realized that we needed in 2015 to update some of our diagnostic methods that were reflected in the definitions because some of the definitions in Chapter 17 hadn't really been updated since the late 90s. And there's obviously newer diagnostic methods that are out there. And then really one of the things that we do a lot of is hear your input, the user input. We get lots of emails every day, and a lot of times they have input on what they think the users believe would be helpful for the definitions or for the data collection. And we always take that into account as we're providing and putting together our definitions. And while we're doing this, we always want to make sure that we're not adding to your surveillance data collection burden because we understand that you guys that are collecting the information have lots of other things to do other than to collect surveillance data, and so we don't want to add to that burden. And of course, doing all of these things together is a Herculean undertaking, to say the least. So the new definitions and modifications for 2015 include the infection window period. We made some modifications to our definition for the date of event of an infection, and that date of event will impact whether or not an infection is considered present at admission or healthcare associated. We've also developed something called the repeat infection time frame, a secondary bloodstream infection, or BSI, attribution period, and have provided some guidance for assigning pathogens as relates to the repeat infection time frame, or the RIT. And these last three, especially the RIT and the secondary BSI attribution period and the pathogen assignment, really are meant to make the data collection consistent and objective. We've tried to remove the subjectivity that previously went along with applying some concepts. I do want to point out that we have online, to make this work a little bit easier, a worksheet for surveillance. It should promote the consistent surveillance data collection. The link is provided here, and we have two supporting documents under the supporting materials. And you should know that there's two tabs at the bottom of each. Sometimes people don't see that, and they don't think they're getting all of the information. We really recommend that you use it, and this is an example of, on the next slide, I have an example of the worksheet itself. So you can see each of the fields of the, we have columns that have the first diagnostic test date, the infection window period, and so on. And so I also want to point out that in the next couple of weeks, we'll actually be having something called a worksheet generator, which is an electronic version of this, which will actually, when you go in and put in the date of the diagnostic test and the other elements, it will make a determination for you based on what you put in of whether or not the event is a present on admission infection or a healthcare associated infection. It'll derive the repeat infection time frame for you and the secondary BSI attribution period. So it's actually all done. We're just having some problems getting it posted in a way that it will allow you to print it and use it as a worksheet. So watch for announcements for that. So I just do want to point out that these definition changes that we're talking about are applicable to many of the definitions, but not all. And the three exceptions are ventilator-associated event surveillance, which Cindy is going to talk about later, laboratory ID events, lab ID events, and surgical site infection events. And none of these concepts are applicable to lab ID or VAE. But as you can see that the date of event is applicable for SSI, and the secondary BSI attribution period is a little bit different, but you're not involved in SSI, so surveillance, so that's the good news for you. We no longer are using a gap day concept in NHSN as of 2015. We used to, previously, we said that all of the elements of the infection criteria had to be present in a time period so that there wasn't more than a single gap day between the elements, trying to frame a time frame during which all of the elements would be together. But we have moved away from that in 2015. We also are no longer allowing logical pathogens to determine whether or not a BSI is secondary to an infection, and we'll talk a little bit more about that. And we've changed the date of event from the date of the last element to the date of the first element, and we'll go over each of these a little bit more in more detail. So moving away from the gap day concept, we've moved now to the infection window period in 2015. And the infection window period is the 7-day period during which all of the site-specific infection criteria must be met. So it will include the date of the first positive diagnostic test. So for instance, for a urinary tract infection, the urine culture, the 3 days before that, and the 3 calendar days after to make the 7-day window period. Some very few infection criteria in NHSN don't include a diagnostic test. There's optional ways to meet the criterion. And if you are using one of those criteria that doesn't have a diagnostic test, you're going to use the first documented localized sign or symptom. For instance, maybe diarrhea. Diarrhea would be a localized sign or symptom for a GIT infection, a gastrointestinal infection. This slide just gives you some examples of what constitutes a diagnostic test. The most common is going to be a laboratory specimen collection, but it could be an imaging test, or it could be a procedure or an exam, maybe that where the physician identifies some infection. It could be a physician diagnosis, and in very rare instances, initiation of treatment can be used. And then some localized signs or symptoms are provided below. Apparently I have some hidden timers in my slides. If there is more than one diagnostic test result, you're going to use the most localizing sign test result to be used. For instance, in mucosal barrier injury, laboratory confirmed bloodstream infection, you're going to use the blood culture. Probably seems obvious. You're not going to use the absolute neutrophil count. So we'll talk a little bit about date of event this year in 2015. So for those of you that have been doing surveillance for any amount of time, you're going to realize that we've kind of done a 360. We've come back to where we were. And the reason that we've been able to do this is because of some of the other rules that we've added, the repeat infection time frame, the 7-day infection window period. So currently now, the date of event is the date that the first element that's used to meet the CDC infection site criteria occurs for the first time within that 7-day infection window period. And it is possible that that element may have been present before the infection window period. Now, I have an example of that later to show you. So here's an example of an infection window period highlighted in green. You see that the urine culture is collected on the 13th, and then the patient had had a temp the 2 days before that. So this urine culture is your diagnostic test. This green period, the 3 days before and the 3 days after, and including that date of the specimen collection, are your infection window period. And in this case, the date of event is the 11th for SUDI, symptomatic urinary tract infection, because it's the date of the first element. In this case, the fever is used as an element to meet the SUDI criteria. Positive urine culture of the required colony count and a fever. So let's talk about how that date of event affects whether or not an infection is present on admission or is a healthcare associated infection. The definition for present on admission is an event where the date of event occurs on the day of admission or the day after admission to an inpatient location. And the POA time period continues, as you may know, the POA time period includes the 2 days before admission. So sometimes patients will come in and they've been at home, they've had a fever. In your case, they're coming from an acute care facility, and they had a fever in the facility the day before they came to your facility. That 2 days before admission to your facility is included in the POA time period. The date of event is however, if it occurs before the patient comes to your facility, so for instance, going back to the urinary tract infection example, if they had a fever the day before they came to you and the day they came to you, they had a positive urine culture, the date of event, you're going to choose the date of event as the date admitted to your facility. We never put a date of event before the admission. So we just go to the first day of admission in that case. Any event that has a date that occurs after day 2 admission is considered a healthcare associated infection. So one of the other big changes for 2015 was the institution of this RIT, or repeat infection time frame. And previous to 2015, facilities would often have trouble because, for instance, maybe a patient had multiple urine cultures collected over the course of their stay, and determining whether or not these represent a single urinary tract infection or multiple urinary tract infections. And our guidance in the past has been that facilities should consider whether or not the patient continues to be symptomatic or whether or not the patient is still on treatment at the time of the second or third urine cultures. But that really is subjective, and in some cases it's hard for facilities or IPs to determine the patient may be on multiple antibiotics, whether an antibiotic is targeted for the urinary tract infection. So created some inconsistency in the data collection. So that's why we developed the repeat infection time frame. It's very objective. It doesn't require interpretation of the treatments, and hopefully it will reduce labor for surveillance, because if a patient is in a urinary tract repeat infection time frame, you may not have to investigate urine cultures that occur in the 14 days following, depending on what's in the urine. So the repeat infection time frame is, it uses the date of event to determine a 14-day window during which no infections of the same type are reported, and the date of event is day 1, and then the 13 days that follow it make the total 14-day time frame. If the date of event for a subsequent infection is within that 14 days, there's no event that's reported. There's no, in the instance, an example of a urinary tract infection, there's no new urinary tract infection that's reported. But if there are additional pathogens in that urine culture, you'll just simply add those. So we have an example here. Again, the green shaded is our infection window period. The yellow, day 11, is the date of our event. Since that's the date of event, we're going to use that day, including that day, 14 days for an infection window period that goes through the 24th. Okay? So any urinary tract infections that would be identified during that time period would not be considered a new event. The RIT applies at the level of the specific type of infection, and the only examples to that, or exceptions to that, are some of the ones that you're involved with, which are the bloodstream infection and the urinary tract infection and the pneumonia infection. So on the next slide, you'll see that we have, in NHSN, we have major types of infections and specific types of infections. And for many of the types of infections, we're going to limit it to the specific type of infection. So for these types here, you may be able to have both a breast infection, and in the same 14-day period, you may have a skin and soft tissue infection or maybe a decubitus infection, which makes sense. Those are separate infectious processes. But for urinary tract infection and BSI and pneumonia, you're going to use the major type of infection. And what that means is that during the 14-day period, you would only report 1 SUDI, and if they had an ABUDI during that same time period, you would not report that. You're only going to report 1 UTI in total during the 14-day period. Same thing for BSI and pneumonia. Okay, so we're going to do a little test. Let's say that your facility is performing CLAUDI surveillance on your medical ward 5 East, and a patient is admitted to 5 West, and the patient's admitted to 5 West on January 15th with a urine culture that's positive for 100,000 colony-forming units of E. coli. No NHSN UTI symptoms are present, so you only have a positive urine culture, and they insert the Foley at the time of the urine culture. So they put the Foley in and draw a culture at the same time. 8 days later, the patient remains with the Foley, and it has a temperature of 38.2 Celsius and a positive urine culture of 100,000 colony-forming units of E. coli again. So the question is, should a CLAUDI be reported for this patient for 1/23/2015? How many people say yes? Show of hands. How many people say no? Show of hands. So mostly people say no. So the answer to this is actually because this patient did not meet the UTI criteria on 1/15, all they had was a positive urine culture. That does not meet criteria for a urinary tract infection in NHSN. You would not be reporting a urinary tract infection on admission. It doesn't set a repeat infection time frame. So this patient has asymptomatic bacteriuria, but they do not have a urinary tract infection. If they have a Foley catheter, they're probably going to have a positive urine culture if you collect urine from them, if they've had one in for any amount of time. So since they didn't meet criteria on admission, there's no repeat infection time frame, and then the patient will meet criteria for CLAUDI. If we go back, 8 days later, they have a Foley catheter, they have a fever, and they have a positive urine culture. They're now meeting criteria for CLAUDI. So at that point, they have a catheter-associated UTI. The secondary bloodstream infection attribution period is a concept that we developed because oftentimes patients will have one type of infection, and then they'll have a blood culture that's collected in around the same time period that may or may not be positive with the same organism that's identified in the infection. And the question is, should this be considered a secondary BSI or related to that other infection, or should it be considered a primary BSI? And the reason this is important is because if it's a primary BSI and there's a central line in place, that becomes a central line associated BSI. Before 2014, we really didn't have a time period during which we said that the blood culture had to be collected in relation to the infection, and we left it up to the facilities to say what was going on with the patient, make a clinical judgment of whether or not you think these two are related. And as you can imagine, anytime you insert clinical judgment, we get inconsistency and variation in the reporting. So we felt that we really needed to put a hard and fast time frame around this concept and when you could say a BSI was related to another infection. So that's what the secondary BSI attribution period is. So this is a period in which a positive blood culture must be collected to be considered a bloodstream infection that's secondary to another site of infection. It includes both the infection window period that we talked about earlier and the repeat infection time frame. So it really just builds on and includes both of those processes or those concepts that we talked about earlier. And it ends up being somewhere between 14 and 17 days in length. And the reason that there's a variation there is that it depends on when the date of event is in the infection window period, and I'll show you that. So in this case, we have a patient that has a urine culture collected on the 13th, again, that's positive and a sufficient colony count. The patient has a fever, and the first symptom or element of the infection criteria is, within that infection window period in green, is on day 10, the fever, so that's the date of event. And you can see that in this case, the secondary BSI attribution period is 14 days because we're using all of the infection window period and the repeat infection time frame. So it becomes 14 days. The next slide shows a case where the patient's urine culture was collected on the 13th, but their temp didn't hit until the 14th, and so the date of event in this case is day 13. And in this case, their secondary BSI attribution period becomes 17 days because you have your infection window period here. Such a bad angle here. And then you have your 14-day repeat infection time frame, and this becomes 17 days because your date of event didn't occur until the midway in the infection window period. And the reason that we give a couple of days here is because we recognize that, sometimes they'll draw blood cultures on patients. That's the first evidence that there's something going on with the patient. They say, oh, they got a positive blood culture. What is really going on with this patient? And then they draw the other cultures. So we give a little bit of a grace period there in the beginning. So the rules that go along with this is that a secondary bloodstream infection may be attributed to a primary site infection during the secondary BSI attribution period, according to some guidelines that we have that are called the Secondary BSI Guide. It's Appendix 1 in the BSI criteria. And there's really only two ways that a bloodstream can be considered secondary to to another infection. One is that they have an organism in the blood culture or blood test that actually matches an organism that is collected from the site. So for instance, a urinary tract infection. They have a urine culture that's used to meet the urinary tract infection definition, and they have a matching organism in the bloodstream that's also collected within that secondary BSI time period. The other way is that some of our criteria actually use a blood culture as an element of the criteria. So, for instance, in our intra-abdominal infection criteria, if the patient has symptoms of an intra-abdominal infection, they have a positive imaging test of an infection, and they have a positive blood culture, that's considered an IAB. And in that case, the blood culture obviously is considered secondary. It's actually it's an evidence of that type of infection. So those are the only two ways. We used to allow, in 2014 and before, the attribution or the determination that an organism was a logical pathogen for an infection type. So again, going back to that intra-abdominal infection, the patient maybe had a gut bug that was collected in their blood culture, and they didn't collect any cultures from the intra-abdominal infection, and they didn't have imaging test evidence of infection. Facilities would want to say, well, they have an intra-abdominal infection. We believe that clinically, and they have a gut bug, so we believe that that's secondary. And we used to say, well, if it's a logical organism for that site, you can say that. But again, that really allowed a lot of subjectivity to be used, clinical judgment to be used, and so we had to pull that out as, the more these definitions and this data is used for public reporting and for payment processes, the more we have to be very consistent so that it's fair to all of the facilities that are reporting. So now, in 2015, there has to be a matching pathogen, or, as I said, the blood culture has to be used as an element of the criteria. So here's an example here. Patient, again, with the urine culture on the 13th and the fever on the 11th and 12th. And then you'll see that the patient has a blood culture that's collected with the same organism on the 18th. So in this case, the date of event for this urinary tract infection, the symptomatic urinary tract infection, is day 11. The infection window period is in green. The repeat infection time frame is in blue. And this blood culture, the secondary BSI attribution period, remember, is the combination of both the infection window period and the repeat infection time frame, is identified by the outer bracket here, goes from the 10th through the 15th. And in this case, the blood culture was collected during that time period, and it has a matching organism in the blood and the urine culture, so this is considered a SUDI with a secondary BSI. Does that make sense? Okay. So we need to talk just a little bit about the disposition of pathogens that are identified both during the repeat infection time frame and during the secondary BSI attribution period. And additional eligible pathogens that are identified within a repeat infection time frame are added to the event. So again, in the case of a urinary tract infection, if a patient during the repeat infection time frame has another urine culture, the first culture was E. coli and the second culture is Klebsiella, during the RIT, you simply add that Klebsiella to the previous UTI. If it was reported to NHSN, you just go in and you'll add that pathogen for the same infection event. Sometimes there are exclusions for specific infection definitions. Again, for instance, in urinary tract infections, as of 2015, we no longer allow yeast to be considered organisms to cause urinary tract infection. And in those cases, you'll have to either attribute that, if that culture is collected, if that organism is identified in a subsequent culture. So let's go back to the example. They had a UTI with E. coli, and then 8 days later they have a UTI with E. coli and yeast. You can't attribute that yeast to the UTI. So you'll have to, if they have a blood culture that's collected, with that organism, you'd have to account for it. So this one, I have a couple of examples to show this. So here's a case. The patient is a 45-year-old patient with a Guillain-Barré that's admitted to the medical ICU, and they have a catheter in place on January 1st. And on the 11th and the 12th, they have fevers. And on the 13th, they collect the urine culture for 100,000 of E. coli. And on the 14th, they collect a blood culture with both E. coli and Candida albicans, again, a yeast. On January 18th, another urine culture is collected, and it has 100,000 of Enterococcus. And there are no other sites of infection present. So let's look at what this looks like. I think that you have just a blank one in your time, or in your packet here, but for time's sake, we'll just go through this. Which of the following is true for NHSN reporting? This patient has an LCBI on January 14th with E. coli and Candida albicans, or they have a SUDI-1A on January 11th with E. coli and Enterococcus, and a secondary BSI, but they also have a laboratory confirmed bloodstream infection with Candida albicans on January 14th. So let's go back to this. Let you think about it for a second. So how many of you think that the answer is A? How many of you think that the answer is B? Oh, very good. That's exactly correct. So let's look at why. Here's our urine culture collected on the 13th with E. coli. Our date of event is day 11 with our fever. Here is our secondary BSI attribution period. It's our infection window period plus our repeat infection time frame. And then you'll notice that we have also had blood cultures collected on the 14th that showed E. coli and Candida albicans. So because the Candida albicans is an accepted organism for urinary tract infection, it cannot be considered secondary to the UTI, even though there's a matching organism in that blood culture. So we have to consider it separately. And because we said there are no other sources of infection to which we could attribute it, we come up with two infections, a SUDI, symptomatic UTI with secondary BSI, with E. coli and the Enterococcus that was collected further down here. Urine culture here that was collected on the 18th with Enterococcus species. That's within the repeat infection time frame for the urinary tract infection, so it just gets added on. But then we also have a LCBI, a laboratory confirmed bloodstream infection with Candida albicans, because UTIs don't allow that organism to be considered a pathogen. And that date of event is the date of the blood culture, the 14th. Now, sometimes a BSI pathogen can be reported for more than one infection type or infection source. An example would be a secondary BSI pathogen to a different primary site infection. Example is on the next slide. So in this case, we have a patient that has a urinary tract infection on the left with E. coli and a blood culture that matches during the secondary BSI attribution period. And they also have an an intra-abdominal infection that's occurring around the same time. They have a CT-guided drainage of an abdominal fluid collection with E. coli in it on the 11th, and the patient had temp of 101 and abdominal pain. So that patient will meet the IAB criteria, and in this case, E. coli is reported for both of these events. Which makes sense. We've identified this organism in both of these infections. Pathogens may be assigned to more than one infection source. Example 2, they may be assigned as secondary BSI pathogen to a site-specific infection, for instance, a urinary tract infection, secondary bloodstream infection, and they can also be assigned as an additional primary pathogen to a primary BSI event. So here's the example here. So in this case, again, we have our blood culture. We have a urine culture collected on the 13th and the fever. We have a blood culture on the 17th. But you'll notice that up here we also had in the beginning, before we had the urine culture, we had a blood culture with Staph aureus. There was no other site of infection. If there was no other site of infection, that would set a repeat infection time frame for an LCBI. And because that LCBI RIT is in effect when that blood culture on the 17th is collected, we're simply going to add that E. coli onto that LCBI, and it will also get added onto the UTI. So the good news is that you're not reporting any more infections here. You're just accounting for all of the organisms. I just want to make that clear that it doesn't result in you reporting any additional numbers of infections. Okay, so those were sort of the global changes that we made in 2015 that affected multiple types of surveillance. We also had some changes to our definitions in, as we call it, Chapter 17, and those are sort of summarized here. We removed, as you may have figured out, hopefully you figured out by now, our bloodstream infection, our pneumonia, our surgical site infection, our UTI, and our VAE definitions from Chapter 17, and only are including them in their own chapters. And they also now cover both device-associated and non-device-associated infections. So we have a chapter that's for bloodstream infection and includes both central line-associated bloodstream infections and non-central line-associated bloodstream infections. That's not a big change, but just you have to get used to where they are. We have entirely removed an infection type called BRON, which is probably not a big change for you all. Do we have any pediatric LTAC facilities represented here, or we have a couple? Okay. And do your facilities have neonates also, babies? Yes. Okay, good to know. So pediatrics is an area where we've heard that they've used the BRON definition a little bit more in the past, and that definition, we'll talk a little bit about why we removed it in 2015. As you know, and as Eileen is going to go over later, we've made some major changes to the definitions for a urinary tract infection, our secondary BSI attribution. We talked about a little bit. We'll be going into a little bit more detail later. And we've added something called the Clostridium difficile infection criteria. So I think just to go back to the BRON information, that included infections such as tracheobronchitis and bronchitis and respiratory infections that didn't meet the level of a pneumonia. And what we found was it was very easy to meet this criteria. It had some very non-specific symptoms and elements in the criteria, and for that reason, we found that it was being sort of unfairly used to exclude UTI or BSIs. So that was the reason that we removed that. The Clostridium difficile infection was a new infection that we developed in an effort to minimize another area of subjectivity and to increase the surveillance consistency. The criteria for CDI are different from the lab ID event criteria and requirements, and they include, like the lab ID, they do include a positive test for toxin-producing C. diff, on unformed stool or the presence of pseudomembranous colitis. And there are no exclusions, it's important to point out, for medications or tests. Sometimes we hear that people will say, well, the patient's on a medication that I believe is causing the diarrhea. Again, it's hard to objectify that and to allow facilities to say, well, I believe this diarrhea is due to medication, so I'm not going to consider that they have CDI. So the definition is important to remember. This definition is not meant to drive clinical practice. That's true for all of our surveillance definitions. It's meant to identify trends in populations. Okay, so let's talk just a little bit about device-associated denominator sampling. So we talked really this morning about the numerators, identifying the infections, which are the numerators in your rate calculation, the number of infections over the number of either devices that are used, device days, or whatever your denominator is. And so it's as important to get your denominator correct as it is to get your numerator correct so that your rates and your standardized infection ratios are correct. We are allowing in 2015 a new method for collecting your denominators. It's an optional method for you, and this is the sampling method, which will allow you to collect the number of patient days and the number of device days in a location. For instance, your indwelling urinary catheters or your central lines just once a week rather than every day. We've done some testing and we've identified that when you do this method according to our guidelines, the numbers that you come out with are very close and they're not statistically significantly different. And so this is a way to reduce the labor that's involved in doing the collection of the surveillance data. You shouldn't be doing this on a weekend. You should be doing it during the weekday. There is some variation on the weekday we found on the weekends. And there are some requirements. You may do this in an ICU or a ward location, not any special care areas like oncology or hemodialysis. And you have to have a minimum of an average of at least 75 device days per month. So you'd have to look at the previous year and make sure in that location that you've had an average of at least 75 device days. We found that's the minimum to make sure that the data that you collect is not going to be statistically significantly different than if you were doing it manually each day. There's an article here that's linked that provides a little bit more detail for that if you're interested in doing it. Again, it's optional. You don't have to do it, but it's there for you if you want to take advantage of it. I've just provided some resources here for you all to look at, and just to summarize that we have removed the gap day concept in NHSN and no longer use that. Instead, we've moved to this infection window period process of identifying infections. We've changed the date of event from the date of the last element during and to the date of the first element during the infection window period. The POA and the HAI definitions have remained unchanged. The reason that we include them here today is because we've changed the date of event, which may impact whether or not, or does impact and may have changed a little bit whether or not an infection is considered present on admission or healthcare associated. And we have instituted some, the secondary BSI attribution period, that 14 to 17 day time period, to try to really make the data for CLABSI more consistent and take out the subjectivity that was involved. And we've actually simplified the BSI rules in that we don't allow this logical pathogen determination, and you simply have to have a blood culture that matches the site, or the blood has to be an element of the infection infection criteria during the secondary BSI attribution period. Our pathogen assignment, if you're in an RIT for the infection type, just add on the organisms. Don't work any subsequent infections of that type up during the RIT unless it's an excluded organism. And we identified that organisms can be added to more than one event type. We talked about removing BRON, adding the CDI definition, and some other important changes. And we also talked about the alternative day count option for weekly sampling for central line types, or for device days. So I want to thank Cindy Gross. Cindy put together some slides that were pretty heavily borrowed from for this presentation. And I think we have time for questions. We have 5 minutes. We got started a little bit late. So I know that's a lot of information. I think they want you to go to the mic because they're videotaping this. So if you go to the microphone if you have questions. Sit down.
Raise your hand if you can hear me. You can probably hear me, right?
I can repeat it, yes.
The alternate method of a denomination collection, that's by location, right? So I have 11 locations in my facility. One location to have 75 bi-state, right?
Each location that you want to use the optional sampling would have to have at least an average of 75 in each location.
Not the whole facility.
Yeah, don't look at your whole facility. You have to go by location type. Location. Thank you. No other questions? All right. Well, I thank you very much for your time.